Good afternoon and welcome to COVID-19 and Myositis, a live Q&A with Dr. Lisa Christopher-Stine and Dr. Christopher Mecoli, both with the Johns Hopkins Myositis Center. My name is Jerry Williams and I am the founder and president of Myositis Support and Understanding. Some of you might know us as MSU. And I'm also living what was thought to be polymyositis for many years. With skin lupus and has now been reclassified as dermatomyositis. But also joining us today as a moderator, I would like to introduce one of our volunteers, Linda, who would like to start by just addressing some things to start with. Hi, Linda.
Hi, everybody. Just a few things before we get started. The session is being recorded and will be available publicly on our website and social media sites. Microphones are going to be muted during the webinar. Time permitting, we'll take a few live questions. If you're called on, we will unmute you and you'll receive a prompt to accept. When called on, please ask your questions as it relates to COVID-19 and myositis without revealing any personal or health information. And please keep your questions brief. We've provided the doctors with a list of questions submitted during registration and via email, and we'll start with those. To type a question, please locate the Zoom toolbar's Q&A icon. Click the icon and type your question. Please do not use the chat for questions for the doctors. Please understand if we're not able to get to all the questions. And myositis patients, join us tonight at 7 p.m. Eastern Time for our monthly Wednesday evening video support session. This is for all patients with myositis. Our video support sessions are a safe place to share and discuss myositis life and COVID-19. Details to join are located on our website and in our support groups.
Thank you, Linda. Also joining today is another one of our volunteers, Jason, and Linda and Jason will work to help moderate the session, along with our Vice President, Lynn Wilson, who will begin by sharing a little bit about who we are and what we're doing to support our fellow patients and caregivers during the pandemic.
My name is Lynn Wilson, and I'm the Vice President of Myositis Support and Understanding. I was diagnosed in 2015 with dermatomyositis. And I found this wonderful group at the end of that year and began, I can't tell you how much that's helped in supporting me. I started working as administrator in 2017 and became vice president in 2019. What I want to do is take a minute to let you know what we as a nonprofit organization, we are myositis-centered, patient-centered. We're an all-volunteer organization, and we're here to help improve the lives of myositis patients through our various services. And I want to tell you a little bit about the three major areas that we focused during the COVID-19 pandemic. Number one, offering educational sessions such as this to help you understand how we can navigate through the pandemic and understand the implications to you of what patient care will be in this time. Secondly, it's around providing. We have a very robust financial assistance program. And during this time, we have, and this was thought about before, but we have increased the monetary amount to $1,500 per patient on a needs basis. We will be offering support, financial support for emergency household expenses, medical bills, and also assistive mobility devices. And third, we're offering support, and we've refocused, kind of pivoted our intent for our support groups. And what we've done is we're offering more support sessions that are patient support sessions, other than the 4 that we really, to focus on COVID-19 issues around the fear we feel and the isolation, and try to help each other. We're doing And we also are looking at some further sessions that will start. Probably we'll announce it by the end of the week, but we'll have them, and they're going to be some fun sessions to help us as a group maybe participate together and help with the isolation issues. So stay updated by going to our website. On our website, you can subscribe to get emails, and that will tell you what's coming up. So with that, I'd like to turn it back over to Jerry. I will just say one other thing, and that's that I am a patient. I understand what we're all going through. You aren't alone, and we are here to help you. So enjoy the session and stay safe.
Thanks, Lynn. So about our guests that are joining us today, both have joined us in the past in various areas. Dr. Lisa has joined us for a couple of video sessions in the past, and Dr. Mecoli has joined us most recently for our Ask the Experts on Inspire, our support community. But to quickly introduce them, Dr. Lisa Christopher-Stine is the Associate Professor of Medicine and Neurology and the Director of the Johns Hopkins Myositis Center. And Dr. Christopher Mecoli is Assistant Professor of Medicine and Director of Research Operations and Physician Lead for the Myositis Precision Center of Excellence at Johns Hopkins. So we would like to welcome them, and we appreciate their time.
I'll start. So welcome, everybody. Thanks so much to Jerry, Lynn, and the entire MSU community. We feel honored to help be part of this session. I would just like to start by saying that, as you notice, both Dr. Mecoli and I do have the Johns Hopkins background. We are very proud to be part of Johns Hopkins, but I want to be clear that the opinions that we express today are expressly our own and do not represent the hospital at large.
Hello, good afternoon, or perhaps good morning, depending on where you are. Great to be here. Thanks for joining in. Just to build on what Dr. Christopher just said, so as a preface, most of our comments today in response to many of your questions are coming from personal opinion or anecdotal data, meaning things that we've read about, things that we've heard from some of our colleagues, things that we've experienced ourselves. At this time, unfortunately, there's no large systematic data of COVID-19 in myositis patients, but it is coming. There are actually two different studies. There are actually many different studies, but two I wanted to highlight. There is something called the Global Rheumatology Alliance Registry for COVID-19, a very official sounding study. That's actually a worldwide study, as its name implies, that originated in Australia and has since spread all across the world. And this is an opportunity for rheumatology providers to enter data about their patients in an anonymous way, so that we as healthcare providers learn more about the disease of COVID-19 as it relates to myositis in terms of risk, medications. So many of the questions that have asked will benefit from a registry such as this. Obviously, many other healthcare providers treat myositis patients other than rheumatologists, pulmonologists, physiatrists, physical and occupational therapy, et cetera, neurology. But this is just one avenue where we're going to actually be gaining data to answer some of your questions. The second study is one that we have ongoing here at Hopkins, perhaps spread broadly, more broadly in the upcoming weeks, which is more of a patient-facing study, where patients might be invited to participate in reporting their specific issues, their social behaviors, medications that they're on, so we can understand things from the patient perspective as well. So although not a lot of data currently, certainly data coming soon down the pipeline.
Thank you both. We have put together some questions that you have asked in advance. So we're going to just kind of start with those questions with doctors here. And if your question, some of these are obviously kind of duplicated. So if your question is kind of dismissed, don't take it personally. It's just that it's already been addressed. So we'll start with these questions that were submitted. The first question is about in-home care, and I know a lot of patients are concerned about this, but as a patient with specifically ILD and PAH, receiving in-home IVIG infusions, the concern is about nurses coming into the home that may be exposed to COVID-19 elsewhere and maybe not be well trained to deal with the totality of the situation. So the question, basically is there a standard of care for in-home nursing? And, is there maybe some suggestions that you could provide?
So this is a question I think that but probably Dr. Mecoli and I can say that we get almost on a daily basis, and we understand where it comes from. I mean, obviously, while there is no large registry of data, I will say that I did look into this question largely prompted by my patients and this submitted question. There is a National Home Infusion Association position statement that has been put out. It specifically does instruct its home care nurses of exactly how to use protective equipment, how to conserve, obviously, N95 masks, of course, if they were ever with a positive patient. I realize that that's fearful thinking that a nurse may be in the presence of somebody who might be either asymptomatic or symptomatic and then going to another home. They are doing telephone-related 24-hour prior questionnaires, trying to screen for any symptoms and not seeing somebody, of course, who would be acutely symptomatic. Again, there are CDC guidelines for social distancing, limiting even contact with immediate caregivers in the home, for example. So the short answer to a really long position statement is yes, there are statements. This is not Johns Hopkins established, but it is established through a national industry standard. Many patients, I think the follow-up to that is, should we continue right now? I think that's an individualized question. I will say that, and I've said to my other patients, that it's probably one of the safest procedures to have done in the sense that nurses are very familiar with how to protect themselves and protect their patient. Again, if you can lengthen your IVIG out and you feel like you're somebody who was wondering if you could extend it, it wouldn't be inappropriate to do that, but I don't think it's mandated to do that at all. I think that I always say that, and you'll see this again come up as a theme, if the disease is left unbridled, it's probably more of a risk than the minimal risk that you might have in actually getting some of these therapies. So I'll leave it there and I'll send it to my co-host over here.
I totally agree with you, Dr. Christopher-Stine. So just perhaps one thing to build off of what you said, one way we think about it is potentially to increase the frequency, meaning, more time between infusions, less interaction with nurses and other healthcare providers. Another thing to at least consider and have a discussion with your primary medical team would be to see if it's possible to get your IVIG infusion over a shorter period of time. So sometimes patients might get their IVIG over 3, 4, or 5 days. Sometimes that's needed so they can tolerate the IVIG. But sometimes that can actually be compartmentalized. And if they were getting it over a 5-day period, perhaps it's possible or worth having a conversation as to whether they could get it over a 4-day period. And that would at least eliminate one day where you're interacting with people that you otherwise may not need to interact with.
And just to piggyback on that, I think that's an excellent solution or a suggestion. The only risk most of the time is that the side effects that we see sometimes, like headache or more severe aseptic meningitis, rarely can be more common in closely spaced infusions or infusions over a shorter amount of time. Having said that, that practice varies widely over practitioners, and many people can infuse over as few as 2 days.
Great point.
And I would just like to ask a follow-up, and I know that this is something some people have talked about. I guess, what is maybe the benefit of talking to your healthcare provider about switching to subcutaneous IG? Would that be something appropriate during this time?
So I've had that very question, and I would say that's an individualized response. I do think that one of the concerns we all have in the IgG community is that sub-Q IG could also go in short supply. So there's only a limited supply, of course, of product. And maybe switching acutely in the middle of a pandemic where you can't be adequately assessed in person as well, since many of our clinics are virtual, might not be the best solution for you. I would say, again, that's an individualized question with your doctor, but it's not something that we haven't considered outside of the pandemic. It's convenient. It can be done by yourself, but do recall that a nurse will have to come into your home a few times to make sure you understand how to infuse. So it doesn't eliminate the nursing component completely. Just going forward, you'd have fewer people in your home, of course. But that is something that really requires some dexterity, a little bit of education, and making sure that the person is suitable. The other thing I will tell you is that IVIG is infused in high concentrations for myositis. So unlike immune deficiency, where you might see a lot of people, you might have seen videos or heard of people with immune deficiencies that use IgG, they have a much smaller volume needed for their disease. For myositis, it's usually up to 2 grams per kilogram, so that can include putting needles in 6 or 7 sites in your body multiple times per week. We're getting better at this, and there are better concentrated solutions, but subcutaneous IG isn't right for everyone, and it isn't always possible for every individualized patient.
So moving on to risk for myositis patients, do you recommend that people who are immunocompromised wear masks and gloves when they leave the house?
You can take this first one, Dr. Christopher-Stine.
So we debate this amongst the world at large is asking this very question right now. So first, let me take the idea of masks. So I'll take you through the genesis of where we were with wearing a mask in public versus wearing a mask in a hospital, wearing a mask at all. Initially, it was thought and suggested that first, there are not enough masks for healthcare providers. So you can't have the entire healthcare force go down because they don't have adequate protection and then can't care for patients. So part of why masks are not recommended or were not recommended initially was for fear of supply. And you've seen that actually come true. So that's one. The second reason is that in general, we do recommend masks if the person is ill to prevent spread of droplets to another person. That's true. The problem there is that just recommending that alone may not be sufficient because now we know that there's asymptomatic spread and that there is community spread that we really don't have a full feel about because the fact is that testing still remains relatively slow and relatively limited. And that actually is, that's, I think, city to city and state to state specific. So how would I answer this? I personally think that we're going to see, and you've seen obviously in the lay press, that the CDC and others, the WHO, who have not previously recommended masks are reconsidering that recommendation. So I would say this, if you have even just a cloth mask, they're not perfect, but they actually have been shown in other studies to help prevent influenza to others. You are probably still protecting others more than protecting yourself. But there is some protection that is afforded by those masks. Do remember this, however, whenever I recommend mask wearing for somebody who is not used to wearing it, the reason that we are concerned is that if you adjust that mask or touch your face or move it, you can in fact inoculate yourself. So if a mask provides you a feeling of protection, that's important, and maybe it reminds you not to touch your face. If it makes you feel like you are protected and that you are therefore less cautious in washing your hands, not touching your face, and doing other things, then I tell you that I think the mask is more of a liability. The long answer. I think we'll see more and more recommendations in real time, but personally, if you're immunocompromised, I think that does put you at an increased risk. And I would not say that not wearing a mask should be a uniform recommendation. But if you wear one, be very careful not to touch your face. Be very careful to remove and wash it if it's cloth, and be very careful not to make you feel like that is a source of protection that makes you immune from doing everything else you should be doing. As far as gloves, same thing. Gloves, again, this is not a disease that goes through the skin, so that if you are able to pump your gas or do something and wash your hands appropriately for 20 seconds, I think all of us know how to wash our hands now. It's the one thing we've learned very well. If you do that, I don't think gloves are necessary. If they make you feel better and you have a cloth pair of gloves that you can throw into the washer, sure, that adds added protection. But if you can wash your hands or have your sanitizer in your car immediately afterwards, it's helpful. Do know that hand sanitizer is not as helpful as hand washing, however. And so ideally, just cleaning your hands after you touch a gas pump, go to the store, etc., is important.
Just to add to Lisa's point, which I totally agree with, one of the benefits of mask and glove is that when you have gloves on, it usually serves as a stopgap, before you touch your face. until you have gloves on or until you're really focusing on it, you don't have any idea of how frequently you touch your face. You could probably just watch me through this hour, and multiple times I'm going to have my hand up here, and it's just subconscious. But if you were to have gloves on, sometimes it's a little bit, oh wait, I shouldn't be touching my face. So potential added benefit of that as well. But I agree with everything Dr. Christopher-Stine said. With regards to the second question here, being immunocompromised, what symptoms should I be looking for if they do not progress as fast as quote unquote normal people? When should I call my doctor, and when should I be worried? So it's a good question. And like so many of the questions today, we don't really have great data to inform our answer to this. But the list of symptoms that I'm sure many people are familiar with now, muscle aches, shortness of breath, fever, cough, sore throat, those are the things people are looking out for. Now, sometimes, I guess, two comments on that. One, immune suppressing medications, particularly prednisone or steroids, can sometimes what we call mask a fever, no pun intended, meaning it prevents you from actually having a fever. So maybe if you were not on that medication, your immune system would have mounted a temperature and you would have had a fever. But because you're on these medications, and prednisone is probably most notorious for this, you may not. So the other symptoms might be a little bit more telling. Certainly if you're immunocompromised and have a fever, that of course is a concern. But that's probably the symptom that I worry most about. Might not be quote unquote normal in patients on immune suppressing medications. The second thing I wanted to say is that if you recall the 5 symptoms, 4 of them arguably are present in many patients with myositis. Muscle aches, yes. Shortness of breath, possibly. Fevers, possibly, and cough. So, I think patients need to get a good understanding of kind of where their baseline is, what's the background noise, so to speak. So if there's anything kind of above and beyond their usual experience, that might be cause for concern. Obviously, that's not perfect because patients will have good days and bad days, and sometimes they'll have a flare. But I think, being conservative and having a low threshold to notify their doctor if any new symptoms emerge is a good plan.
I think that's a very comprehensive answer for sure. The only other thing I'll say, again, it's in the lay press, but anecdotally from some folks who have reported to me their positive status, they talk about an unusual smell or lack of smell and taste. You may have seen this. Again, this is not one of the foremost symptoms per se, but should you have a very strange smell along with an increase in symptoms, et cetera, that may be something to be helpful. The other thing, again, anecdotally, is that while you could hurt all around, like the flu, these myalgias, muscle pain, muscle aches, in some, again, this is more anecdotal, but seems to be that the lower calf tends to be an area where myalgias seem to be a little bit more intense. But once again, I really want to clarify all these statements that this data is definitely not in large studies nor verified, but just giving you a few thoughts of some of the things we're hearing.
What would be, I guess, the impact of being immunosuppressed with the virus? Obviously, it does put us at a more significant risk of catching COVID-19. And then follow up on that is with more specifically inclusion body myositis, aside from being maybe in the elderly category, minus any underlying conditions such as obesity or diabetes, heart disease, does just having inclusion body myositis put you at an increased risk?
You want to take that, or shall I start, Chris?
Go ahead. I'll follow you.
I mean, I think the big answer is we don't know yet.
Right.
So the impact of being immunosuppressed, yes. So, and I think that Dr. Mecoli will probably echo this. There is some small data that maybe being immunosuppressed makes you more susceptible to the virus, but perhaps because of this idea of what some people call cytokine storm, or when the immune system becomes so overactive that in fact is contributing to some of the brisk lung injury that we see. That's not entirely clear or substantiated, but many people feel that's possible, and that's why you have heard, and I'm sure we'll get there, of using immune suppression or immune modulators to help. So one thought is, well, yes, you actually may be somewhat more predisposed because your immune system is blunted by the medications, with the caveat that having an unbridled autoimmune disease in itself puts you at risk. So I don't recommend stopping medications without a very good discussion with your doctor or your provider to have a risk-benefit discussion. I have almost uniformly not stopped immunosuppressants in my patients unless I thought they were doing very well and we were going to stop them anyway. Does it put you at, maybe it helps you when you're fighting the virus? That's a theoretical concern, and I'll actually have Dr. Mecoli speak to that point because there is some data there.
So I can add on a little bit, just to paraphrase what Dr. Lisa said. So we know that in patients with various forms of myositis, and admittedly it's more of the not IBM forms of myositis, dermatomyositis, polymyositis, necrotizing myositis, etc. We know that just by having the condition puts you at a little higher risk than the general population of several different types of infections, viruses and bacteria. On top of that, treating them with immune suppressing medications increases that risk further still. So if you extrapolate from this data that we know, yes, it is possible that it's more likely for you to actually get the viral infection of COVID-19. Again, theoretical. But to Dr. Christopher's point, the big thing that we worry about with COVID-19 isn't the, typical viral symptoms of having a sore throat and fatigue. It's the severe lung inflammation that can result, this whole ARDS or respiratory distress syndrome that you might be reading about in the news. And that's what's thought to be mediated by the cytokine storm. There's a theory that if you're kind of suppressing your immune system because you're trying to get control of your myositis, perhaps you're not at risk for having this overwhelming lung inflammation, this ARDS, which is resulting in a lot of patients being on ventilators and being quite sick. So it might be kind of a double-edged sword a little bit, a little bit perhaps beneficial, but also obviously putting you at higher risk. Again, I emphasize that this is all theoretical. There's no data that supports any of these statements I'm saying. We're extrapolating from other types of infections.
And I think that Chris already spoke to IBM. So I think that the problem with inclusion body myositis is that even at a baseline, we debate in the medical community whether this is mostly neurodegenerative, whether this is autoimmune, or whether this is both. And because of the fact that we don't even have a great handle on exactly what inclusion body myositis does to the immune system, again, it's incredibly hard to say that you have an increased risk over the general population. I think theoretically, maybe a slight amount, probably not so much as the other myositis syndromes that Dr. Mecoli just mentioned. Again, I think it's said here, and I think it goes without saying, that that group just tends to be in the older population. Again, this disease is severe, even in the young, in some cases, which I'm sure you've heard, but just being elderly in general puts you at a risk category, and that just tends to be the demographics of inclusion body myositis. So I don't know that we really know enough about the immune compromise. The second thing I'll say is that some patients with IBM do have some overlap with, for example, Sjogren's syndrome. Some people just have the antibodies but don't really have Sjogren's symptoms, this dry eye, dry mouth syndrome that you may have heard about. Again, those patients may, in my mind, have a slightly increased risk because it's a different way to turn on the immune system. But I just think that our answer of being so unsure highlights, A, we know very little about the virus alone in immunocompromised patients, and B, we don't know all that much about IBM as it stands, and that makes this question so hard to answer. But hopefully with time, we'll be able to give you and share more data as we learn.
Kind of going off of that, should upcoming appointments with specialists such as Hopkins or rheumatology in general, do you feel that those should be postponed if telehealth isn't an option?
I'll start. So many practices, this varies across the country. I'll just give you an example. For our practice, we've been almost 100% virtual since, I believe, March 16th for sure. We feel like the risk of having a patient exposed in an outpatient setting is great, and we don't want to take that risk. Also, we're conserving all of the PPE and other resources in the hospital by decreasing or eliminating elective patient appointments. Now, obviously, your appointment with your doctor to monitor your disease is not elective per se. If it's non-urgent, and actually even all urgent visits at this moment are deflected to a more urgent care setting in our practice. So what I would say is that if you can have a video visit, these rules get relaxed every single day as to which states we can provide video visits. We are by and large converting all of our visits that can be to video visits. And that I think has been helpful. If you don't have telemed, there is the telephone, and we can both provide, obviously advice over the phone and even conduct a visit over the phone in several states. In the states that we're not allowed to bill for that, for example, for our services, we could obviously, as always, still speak to you. So I think it's worth keeping in touch with your doctors, recognizing, of course, that we are a bit inundated and trying our best to keep up in real time with all of our patient needs. So some patience would be greatly appreciated, and we've seen that in our own practice. All of you have been so generous and understanding. So yes, you should check in, probably not in person for the next several months. And I would recommend checking in the ways in which that telemedicine is allowed with regard to the practice you're in.
Totally agree. I mean, I think one thing, just taking a step back, thinking about how this whole pandemic is going to change healthcare in the future, it's definitely caused, some of us, at least here at Hopkins, Dr. Christopher and I, were talking about this, realizing we may not need to see patients, as much as we thought we did. And that, for a lot of those that travel a lot, and it's not easy to get to an appointment sometimes, maybe we could space out the visits a little bit more than we thought originally. There's still a lot of value of seeing patients when they're doing well, when they're not always in extremis. But to the point of this question, I do think postponing is totally reasonable, as Dr. Christopher said. Agreed.
Thank you. I know one of my hopes coming out of this is that the telemedicine will kind of be more available in the future after all of this.
As the Deputy Director of Telemedicine for our division, you preach, please preach, say it loudly. I couldn't agree more. It is time. I would never have ever wanted it to be thrust into the spotlight like this, but I think there are some silver linings, and doctors are recognizing the value of telemedicine. So I do think that we will come out stronger in that regard for our patients.
Great news. Thank you. Thank you both. So moving on to the next question, which I think we've kind of addressed, having polymyositis, not being on any type of medications for 4 years, at age 51, increased risk in comparison with the general population.
I think that was probably recently stated that anybody with an autoimmune disease, even in remission, probably doesn't have a completely normal system, completely normal immune system. But if you were to ask me who is at more risk, somebody off meds or somebody on meds, that doesn't need them currently for their disease, and certainly it's probably stands to reason that there's a slightly less chance that you would be able to contract the disease if you're not currently on any medications and you're in remission. But you might have a theoretical increased risk just by having an aberrant immune system. Again, this really is under the giant answer of we just don't know enough yet to really be comprehensive in answering that.
Agreed.
So, again, I know that a lot of this, like you said, is, you don't know. There's not a whole lot of data. But pulmonary risk for IBM patients based on pulmonary function numbers. Any thoughts?
I think my thoughts are twofold for IBM patients and COVID-19. One, we do worry about, I guess, these pulmonary function numbers, meaning if their respiratory muscles are weak and they're not able to breathe as they otherwise would normally, that might make it worse for them if they were to acquire the virus. I don't think it necessarily increases their risk of getting the infection, but if they do, that's just an added stressor on their breathing function. Similarly, I worry about those patients with IBM who have issues with aspiration. If just thinking about the lungs, any insult or any harm to the lungs, regardless of what's doing it, I would think is a little cause for a little more concern. And if patients have really bad aspiration, COVID plus aspiration pneumonia is probably worse than just COVID alone. And given the fact that IBM patients, at least some of them, are at risk for aspiration, those are the ways that I would kind of risk stratify in my mind. I don't know, what do you think, Dr. Christopher?
I couldn't add anything to that. I think exactly the same. I think that's absolutely right. As far as the second one, I wonder what the odds are of surviving COVID-19. I'm 71, I have Sjogren's, I'm male, I have RA, I have IBM for 22 years. I feel like this is a board question to which I don't know the answer. So taking it apart, you're 71. Of all of those numbers, of all the things you just told me, what we know about the virus is your age puts you in a higher risk category there. Sjogren's is an autoimmune disease, and again, maybe an incremental risk there, but we talked about the fact that maybe we just don't know. Similar with rheumatoid arthritis. IBM, we talked about all of that. So I think that of all of those comorbidities are, all things that contribute to your illness score, for example. I think that the 71-year-old part of that equation is probably still true as the highest risk factor. If I compared you to a 71-year-old with no prior medical history, of course, I think it stands to reason that you have an increased risk of survival per se. Again, I also think you have a decreased risk of surviving the illness compared to a healthy 71-year-old. But again, that is all just because any insult to the immune system theoretically may cause that to be true. But honestly, the answer is we don't know. Of course, we were discussing right before we got online that, I'm sure you've seen it. There's 90-year-olds. There's a 102-year-old woman, for whatever reason, she survived it. So it doesn't mean it's a death sentence. It just means that any additional health problems, in addition to advanced age, certainly likely puts you in a higher risk category for sure, for both getting the disease and surviving it. Want to take the next one, Chris, or do you have anything to add?
No, I don't. I'm just looking at the last two questions. I think I would answer them actually rather succinctly. So should high-risk patients take off work for a few weeks? I think my answer would basically be social distancing. So if you can, yes, in the spirit of social distancing, as long as you're not an essential employee, if you have the ability of teleworking, I would certainly take advantage of that and try to minimize interaction with others, including coworkers. To the second, what should we do if we have to go to the hospital? I think first and foremost, you'd make sure you do in fact need to go to the hospital, and that's probably worth a conversation to your primary doctor, primary provider, because if you don't need to go to the hospital, that's certainly the last place you should be. And other than letting them know, sometimes they can call ahead and let the ER know that you're a specific patient with these specific issues, and that can sometimes grease the wheels. But ERs, as you can imagine, are inundated at the moment with a lot of patient volume. So if we can minimize it in a safe way, patients going to the ER, we certainly should try to do so.
The only caveat I have to that is the converse situation, which I've been thinking about, which is, of course, that heart attacks and appendicitis and all of the things that befall people still happen in a pandemic. So I would just say the counterpoint to that is, please don't avoid hospitals at all costs and then die of a ruptured appendix. So I think as Dr. Mecoli just said, assess your need to go to the hospital. Your need to go to the hospital is still the same in an acute situation, even in a pandemic. And we are doing everything we can at our hospitals to protect patients who do not have COVID-19 from getting it.
Great point. Yeah, agreed.
It is a great point. You get kind of thinking in this box sometimes that, but yes, if you're having severe abdominal pain, you might need to. Yeah.
Please go.
Thank you both for addressing that. So moving on to the next set of questions here, stress and COVID-19. Thoughts about that?
Said this very point. I'll say it publicly. I've said it to my friends. I say it to my patients, and I'm trying to practice it myself. Outside of a pandemic, I think those of you who have ever seen me as a patient know that I really try a holistic approach to medical care. In addition to the medicines I give, I spend a lot of time talking about your mental state, your family support, how you take care of yourself on a daily basis. I am a firm believer, I will go on record to say that while the stress response is very hard to study in an academic setting under controlled circumstances, I have seen enough instances that make me believe that stress exacerbates disease. A lot of stress sometimes seems to precipitate the onset of disease. And there is enough data that suggests that your own mental attitude and stress toward daily practices does in fact hamper your immune response if you have a lot of stressors. That is true. So within our capacity to handle all of this data, I think the answer to the question is yes. What do you do about it? And I'm going to give you a prescription that I have given myself and my patients. Limit your news and social media coverage. I am giving you that as a warning and as a prescription, and it is a mandate to myself as well. It is hard when you are stuck in a house not to watch or read news 24 hours a day. I believe it is one of the single most contributing factors to making people feel anxious and panicked. Limit your news, definitely get your news, but limit it to a few 15, 20 minutes in the morning, 20 minutes not right before bedtime. Give yourself a 2-hour window before bed and do not look at the news because you won't get adequate sleep, which is also part of the stress response. And make sure you take a walk and get fresh air if you are able. So those kind of things, I think not only do we talk about how stress affects the immune system, we really need to address practices holistically, including meditation or whatever you can do to make your stress response decrease.
Took the words out of my mouth.
We're like the same person.
Thank you for that. And that's part of the reason that we're going to be introducing some fun activity sessions, video activity sessions for the myositis community coming soon, including some games, things that are just, we can come together as a community who understand each other's fears and, you know, needs and mobility issues, but can also just have a good time together. So I think that's a good point.
Fantastic.
Just regarding the second component of this, I'll be getting Rituxan in the near future. I think this is a relatively common question. And the concern, of course, is that rituximab can last quite a long time. You know, how do you weigh that risk benefit? And then getting back to what Dr. Christopher said, there is a true risk benefit. I think many people would argue that the risk of not getting the medications you need to control your myositis is probably greater than the increased risk it may cause of having you develop COVID-19. You know, anyone who's had a flare of their myositis or very active disease knows in that instance, you tend to get a lot of different immune suppressions, steroids, Rituxan, many other medications as well. So it might be the lesser of two evils to just continue your maintenance therapy, whether that be Rituxan, whether that be your usual oral medications that you're taking to avoid any type of flare over the next couple of months. Dr. Christopher.
I think the only thing I would add to that, again, very anecdotally, but I have noticed this over the last nearly 2 decades of giving rituximab. Again, you'll all tell me stories of terrible infections that might have happened. But in general, I do think rituximab is very well tolerated in patients with myositis with relatively few co-infections. I've actually been very surprised at the tolerability of that drug. And it's not always true against all autoimmune diseases. Again, that is completely anecdotal and observational in my own practice and my own patients. But I do think that rituximab is generally well tolerated and does not put you at an enormous increased risk. Having said that, because we just don't know, and any immune suppression can be contributory, if you can push it out a bit and your doctor feels like the risk benefit is in the category of risk right now, then certainly push it. But if it's felt that your disease will be unmasked and it's going to flare, by all means, I think that you should get the infusion.
Jerry Lynn et al. I don't know if, so around like, I guess, 10 of, do we perhaps want to look at the Q&A and see if there's some themes that we might be able to address, or maybe just continue going with questions? What do you guys think?
If you don't mind, I would definitely like, I would like to get to one of the big, we can come back to these, but I would like to
Maybe we need part 2, Jerry. We might need a part 2.
If you guys are open to that, we're definitely open to it, because I know you guys do have a strict time limit. But I know that there's a lot going on with the hydroxychloroquine, Plaquenil, a lot of questions about that. Is that something that you guys could maybe address now, and then we'll take a look at the Q&A real quick?
Sure. So now that hydroxychloroquine has been approved, is there anything we as patients can do to ensure continue to receive hydroxychloroquine? So it's a great question, and definitely a concern throughout the entire world right now. There are a lot of patients who are on very stable doses of hydroxychloroquine that's providing them a lot of benefits. I think some small things you can do is, sometimes you can request a 3-month prescription, which can sometimes, provide you a little bit of extra medication and not have to do a monthly prescription if that's allowable by your insurance and your provider. That's one strategy to go about this. I will say, and again, this might be a little controversial, but I find personally, Dr. Christopher, please weigh in here, that hydroxychloroquine is rarely the magic bullet for myositis, meaning it definitely can provide patients with a lot of benefits, but usually if patients need to be on a medication, they may need a little bit more than hydroxychloroquine. And I imagine that the overall benefit that the medication is giving them is relatively small. And again, I don't want to minimize, a patient's benefit to hydroxychloroquine. It definitely can be greatly beneficial. But I would actually worry about other medications being on shortage more than I would hydroxychloroquine itself. But I understand that's a little bit of a controversial statement. I'll turn it over to
I tend to agree with that. I mean, I do think some people really do depend on it, but I think that's for the minority of patients. I also will just say that the current, the study that was initially done, I believe, had only 20 patients. The reality is that the data that's coming forth, this is a cautionary tale about observational small studies without randomized controlled data coming to light. So while this is still formulaic and people are using it for very critically ill patients, we are unsure this even works. So I think the problem is that we now have unleashed this. The FDA has pushed it through quickly, and we just really don't have enough data to support it, which may change supply chains in the future. If you do need it, a 90-day supply is preferable if you can get it. We do recognize, particularly for our lupus patients, in which hydroxychloroquine really can be very important. There are shortages, and we recognize them. We're doing everything we can, but right now I think it's just too fluid. And then chloroquine is a replacement, but again, also in short supply. Jerry, I'm thinking, as I'm looking at this, there are so many wonderful questions in the typed Q&A that I'm wondering if it might make sense for Dr. Mecoli and I to take a look, to type the answers, not now, because I can't type, but to talk about those answers and maybe put that up as a separate document, like your questions answered, including those that we didn't get to in the slide set, just to try to be as comprehensive as we can. I think there are wonderful things coming in about the safety of pills and groceries, and again, a lot of I don't know, but I think we might be able to help with some fears if Dr. Mecoli agrees. I just think in the interest of time, we can answer some, but those that aren't answered, we might be able to.
I type very quickly, so I can probably dictate your responses.
That's good.
Perfect. Oh, yes, perfect. That would be, if you guys want to do that, like, you mean after the session?
Yeah, so for what we don't get to that
Sure.
seems to be something we could answer, I think maybe that would at least help for people that just can't get their answers. And I think they're asking wonderful questions, but what we haven't figured out how to do is to stop time.
Yeah, exactly. Did you want to, is there anything in specific in the Q&A that you wanted to address right now while I go back to the slides?
I'll say, so a question about IVIG, do we have knowledge about whether it'll affect positively or negatively? We don't regarding COVID-19. What I will say about the safety of it is that there's none right now, the supplies that are currently given are not, were donated prior to, I believe, even community spread of COVID-19. And these are radiated. So viruses are well radiated. There is no suggestion that COVID-19 will be something that patients will be able to, quote unquote, catch through IVIG. Again, if that data should change, I can update you. But my understanding and speaking to all of the IVIG community is that, in fact, that's one worry that currently we can take off the table. Whether you'll get antibodies and whether it'll be protective, again, we don't know either. Probably not. But I think IVIG safety currently is okay. Is the Johns Hopkins study looking for additional volunteers? Are they using their current patients? Chris, you're heading a lot of that. I'm going to have you do that. That's the patient-centered outcomes at Hopkins. Do you want to take that question? It's whether or not you're using current patients or looking for collective data.
Sure. No, thank you. At the moment, it's constrained just to the Johns Hopkins health system. So any patient with any autoimmune condition, myositis, multiple sclerosis, et cetera, There's talks about expanding that, but as of today, that has not yet happened. So if of course that does happen, we'll certainly let everybody know so we can share in that invite, abiding by IRB policies, of course. But at the moment, it's just internal.
Do we have an opinion regarding information about the safety of pharmaceuticals? So you're saying, well, are people touching my pills and then giving them to me? Can I get COVID this way? I'll answer that is the same way I'd answer the slide that's up, is food and delivery and safety, and should we order takeout? So again, we don't really know. Some of these studies, one of which is produced in the New England Journal, says that this virus can live on cardboard for 24 hours. True. Let me just caution you. Do I wipe down my cardboard boxes or leave them for a day? I do. Do I think that people are getting COVID-19 from their Amazon packages? I don't. I don't think that's a major spread or known right now. I may have to back off that statement. I mean, I think that if you can fit your stuff out that's being shipped to you from delivery services other than food, then do that for a day and then unpack them and wash your hands. Or food, I think that most people feel that the transmissibility through food is not zero, but probably pretty negligible. When you talk about a substance staying on plastic or staying on cardboard or staying on anywhere, that means that traces of the virus are found there. It does not mean necessarily that you can transmit that virus. You need a minimum dose, per se, of viral transmission in order to actually get sick. So I think you should practice hygienic practices. I have not yet seen a study that tells me that anybody's being infected from takeout or their pills. And so to date, I would say we have no data that suggests that increases your risk for transmission.
The only thing I would add, if I may, is that if you are, going to get delivery service, for example, there, you can minimize exposure. So obviously opt for delivery as opposed to picking up, pay with your credit card in advance. Anything that decreases the items you touch is basically a good one. So I would just kind of keep that in mind for those eating out to support restaurants these days.
Absolutely. Some of these are a little too specific. I'll deflect.
Right.
I'm happy to answer those. I'm going to try to get them more for general. I'm going to the one where I have DM. If I become infected, should I continue with medications? Again, so if you are hospitalized and or should you continue? This is a good question. I think, again, I'll ask Dr. Mecoli's opinion. What I have been recommending, that is, if you in fact become infected with COVID, you should discontinue your immune suppressants for the time of infection. Currently on prednisone, CellCept. Now, with the caveat that you can't just stop prednisone unless you've been taking it for only a few days. So you can take Tylenol with prednisone, but we would recommend stopping most likely all but prednisone, and then you would have a conversation with your doctor or the rheumatologist on call in the hospital as to how to modify your immune suppressive regimen. And I'm interested to hear Dr. Mecoli's take on that.
No, I agree. I think sometimes, specifically with regards to prednisone, you can actually do more harm than good by stopping your prednisone cold turkey, especially if you've been on higher doses for a long period of time. So I totally agree with what you said.
Could we address, before you guys have to go, could we address the Advil ibuprofen question?
Yes. I'll start, and I see Dr. Mecoli, I'm sure, has an opinion on this. This data came from a theoretical mechanism of the way that the spike protein, one of the parts of the virus, the way that it attaches in the pulmonary system, there's a theoretical mechanism as to why NSAIDs might exacerbate that process. There was a French statement that went out to say that NSAIDs were contraindicated or prohibited or not recommended. I believe this is true, that EULAR and ACR, I believe that there's now a position statement to the contrary, that we have no data to support that position. So I have not suggested that anybody stop NSAIDs if they need them. Should you need an NSAID and you need it for fever and need something, you can take Tylenol instead. Tylenol is a better fever reducer in general, so Tylenol is actually preferred for symptomatic treatment, in my opinion. That's just medically across the board. But I think that I have not seen anything to contradict my opinion that NSAIDs should not be stopped or avoided based on the data that's available.
I'd agree.
Great, thank you. Did you want to end here, or did you have time to answer a few more?
We can, it's up to, I'll make the call. Dr. Mecoli is actually valiantly covering the inpatient service now, so it's his call.
I can probably go five or 10 more minutes, Lisa.
I say that, yeah, I'm happy to go for another few minutes.
Okay. Is there anything in the Q&A that you would like to address?
Let me see.
Specifically?
Oh,
yeah,
so I'm go ahead, please.
Sorry, I was just going to say, because I think I saw this question a few other times. I think most people are aware, but if they're not, IVIG and hydroxychloroquine are kind of unique in terms of our medications we prescribe, in that they're not actually immune suppressing medications. And again, I think most people are aware of this, but I just thought we'd formally say it. We actually think them more of immune modulators, basically modulating the immune system. So they certainly work, as anyone who's taken these medications could perhaps attest to, but they don't really increase the risk of infection the same way other medications may that patients are familiar with: methotrexate, azathioprine, mycophenolate. It's a long list, as you know. But the IVIG and hydroxychloroquine are not thought to really increase your risk. So you shouldn't have perhaps the same concerns being on those medications, other than the things that we've talked about, interacting with nurses, home care, et cetera.
Agree. I'm looking at the slide that's up. I think this is probably reasonable. These are related questions. So somebody's the daughter of one of my patients and would like to know what precautions family members need to take. So I'm not sure if this comes from the fact that you don't live together. If you live together, the answer is that you're all in the same space, per se. If you don't live with that family member and social distance needs to be more than just social distancing, the answer is that many people have taken the stance that they're not going to visit their family except through FaceTime or other video mechanisms to meet with them to decrease their risk. So again, it depends on how isolated you are, but I think that social distancing is still what we prescribe, and then to try to limit all of your interactions to the best of your ability, trying to stay only within your own nuclear family. For the second question, if you work outside the home, so here's somebody who's a caregiver but has to work in a government on-call job, what precautions should they take in and outside the home? There, I think there's, again, some recommended suggestions are to take your shoes. This is true for anybody coming in outside the home, but certainly a worker outside the home. What I would personally recommend, when you come home, take your shoes off. If you can take them off like outside or something, leave them in one place. Immediately take your clothing off and shower, if you really want to be as protective as possible. So shoes, showering, and launder your clothing in hot water. That's all that I can think of outside of obviously being socially distant at your job itself and trying to minimize that social risk.
I agree with that, and I'll just add that if you can use some type of Clorox wipe spray on the doorknob or keypad or alarm system, I would do that as well.
That should actually be done nightly, and I think we all need to get into that habit. People come into our doors, etc. So wiping down, if one could get wiped, recognizing these things are going to be in short supply for some time. Wiping down everything in the house that are high-touch surfaces and doorknobs. That will apply more when we all go reintegrating back into society, when many of us are going back. Actually speaks to the question here. What are our views on longer-term strategy? I honestly think, I'm curious to hear Dr. Mecoli, my own opinion is that you're right. A reliable vaccine is a long way away. And, you know, some people flare with vaccines. This one I might take a chance with and get the vaccine. I think your chance is higher of we'll see how well the vaccine protects people, but likely I think that's going to be a good thing to do. What's the long-term strategy? It's probably going to be on a rolling basis, recommending how we reintegrate into society. I don't think realistically many of us should be going back to work, if we're able to not do that, for weeks to months. And so, again, the best way, I think to practice is good hygienic practices is to try not to get sick and do within your confines that you can. It's about 6 feet for droplets, for forceful droplets to be able to reach another individual. People have talked about this idea of airborne. The virus is not thought to be airborne per se, but it is suspended in air briefly, which means that you just need to maintain a good distance. We are all going to be 6 feet apart from each other for the foreseeable future within reason. We just are going to have a new normal for the better part of a year, in my opinion. I also think that anytime you eat, anytime that you come into or out of a space, out of the restroom, of course, always to wash your hands. If you can't remember the last time you washed your hands, wash your hands. So washing your hands, and then also keeping them, actually, which again is not a small thing. For patients with dermatomyositis, my own hands are so red raw. I think a lot about my patients and how their skin must feel today washing your hands. So getting an emollient cream, this is not subtle because you don't want broken skin. We don't have the virus through our skin because it's protected. You don't want to have anything come in through your skin. So making sure that when you wash your hands, you are also diligently, especially at night, using something like Eucerin or CeraVe or something with a high amount of emollient cream to keep your hands soft.
I'll just say that I totally agree, and I'm willing to, with Dr. Christopher, sit down and try to address the bulk of these in pen and paper form, at least the themes that I see emerging from several of the question categories.
We would definitely appreciate that. And we have a volunteer at MSU that has just informed me that if you dictate your answers, she would be happy to type up them for you. So that's an option if you are open to that or need help with that.
Someone knows my typing skills, yes.
I'm biting my tongue here, Dr. Christopher.
Right. Well, I think that ends our session for today, and we will be following up with you as the attendees with some follow-up on the questions and additional sessions. We thank you both. Thank you, Dr. Lisa Christopher-Stine. Thank you, Dr. Mecoli. We appreciate your time today. And I know it's frustrating because you don't have the data, so there is a lot you don't know, but we do appreciate you sharing your opinions and what you do know. So again, thank you. And if you guys need to run, I totally understand. But I just do want to do some final comments for those that are attending. We appreciate your time joining us today. Again, this session is recorded and we will have it available within the next couple of days on our website and on social media. And if you have any additional questions, please feel free to contact us. If we don't have answers, we will try to get them for you. Our email is info@understandingmyositis.org. Our comprehensive website, understandingmyositis.org. And if you're interested as a patient or caregiver in sharing your experiences with myositis, even the COVID part of this, the fears, anxieties, social isolation, distancing, visit myositislife.org and you can actually submit your story, short videos, photos, memes, all kinds of great things. It's a great way to get education and the patient and caregiver experience out. It is a public website, so these things will be shared publicly and help promote awareness and better understanding.
Stay safe, everybody, and we'll try to get Dr. Lisa and Dr. Chris back for another session soon.
Yeah, we'll talk them into it somehow.
Yeah, we'll
We're good. Thanks to all of you at MSU. Thanks for everything you do for the patients. We could not be more grateful, really, as doctors, for how much you support everyone going through this. So thanks so much.
We appreciate that. Thank you. Everybody have a wonderful rest of your day. And for the patients, myositis patients, join us tonight, 7 p.m. Eastern time. So join us for the video support. And, we hope to have a few laughs during the session as well, but we'll talk about COVID-19 and your experiences, what you still have questions about, your fears, anxieties, all of that stuff. Join us, 7 p.m. Information is on our website. Thank you.
Thanks again.
Bye-bye. Thank you.
Stay safe, everyone.
Bye-bye.
Thank you for joining today's webinar, COVID-19 and Myositis, a live Q&A with Dr. Lisa Christopher-Stine and Dr. Christopher Mecoli. Myositis Support and Understanding is working to improve the lives of and empower those fighting myositis through education, support, awareness, advocacy, patient financial assistance, and access to research. Visit our comprehensive myositis website, understandingmyositis.org. And be sure to check out our newest website, myositislife.org. Read the experiences of myositis patients and caregivers and share your own to help promote awareness and better understanding of myositis.